We are going to switch gears and talk about custom patient-specific pre-contoured rods, pros and cons. We continue with the heavyweights, the titans in the deformity world. We've got two just, full professors, published hundreds of articles, influential in the deformity world. We're going to take two sides of this. Peter Passias, who has joined the trend of leaving a place and joining Duke, will take the side of pre-contoured rods, the lazy side. Will give us the pros and cons of that. And Sig, I ran into Sig. He was in the gym for 3 hours this morning already, so he's ready to bend those rods and get the same outcome. So we look forward to the debate. And first up is going to be Peter.
Well, thanks for the introduction, and it's an honor and privilege to be here. These are my disclosures. I have received research support for research on this topic, so take what I have to say with a grain of salt. My biggest disclosure is I really think Sig is one of the greatest minds we've had in the last few decades. But that's the important point, in the last few decades. And we're not... We're now in the modern era, and if anyone who does spinal deformity surgery and doesn't think rod fractures and pseudarthrosis are a problem, I think the next talk is going to be a really good one for you. The fact of the matter is, this is the biggest cause of reoperations that we face. Up to 38% of reoperations are related to rod fractures and pseudarthroses. And this is a significant cost. If you look at a very underestimated additional cost to our surgeries, already very expensive surgeries, it's an additional 70% for a reoperation for a rod fracture. If you look at the impact on our outcomes, these patients are less likely to achieve MCID and by fourfold. And if you look at the overall value, it's diminishing the value of an already very expensive operation. So how common are these rod fractures? Well, if you look at even idealistic state, the ASLS is probably the best literature we have, $3 million NIH-funded study. And if you look at their rates, there were no revisions, no major sagittal deformities, and a low rate of 3-column osteotomies. Overall, about 40% at 5 years. If you project this out to 8 years, it's about half of patients are failing their surgery with a rod fracture and having to be treated further. The fact of the matter is, even if you do have a radiographic assessment of fusion at 2 years, that's confirmed with CT scan, as Alan Daniels showed us, you're still not out of the woods, and you can still have a 10% rate of fracture in the next 2 years. And this is confirmed with the ASLS data as well, where you can see the peak rate is at the 2 to 3 year mark, but you don't eliminate this problem if you follow up these patients between 3 and 5 years. What is the fate of rod fractures? Well, it's very simple. These patients really have reoperations. If you follow them 6 months to a year out, as you see in this study, 60% of these patients have a reoperation. If you follow them 3 to 5 years out, 75%. And if you follow them up to 10 years and beyond, it's almost 100%. So this is really a problem we have to fix. And the old adage of unilateral rod fractures versus bilateral fractures really doesn't hold, because if you follow these patients, the unilateral fractures out long enough, they become bilateral fractures. So can alignment save us? You've seen a lot of talks at this meeting about alignment. The short answer is no. Justin Smith showed us that the major risk factor for rod fractures was the degree of correction. And if you look at all these new and great alignment schemes, the most accepted one, the SRS Schwab classification, up to 30% of patients who are perfectly aligned still have rod fractures. If you look at a classification scheme directly designed to prevent these occurrences, the last 4 PubMed publications, no correlation with occurrences. Let's talk about a little bit of the basics. These are the typical cases we do. And the fact of the matter is, and I'm not sure why this patient's having a stress test and was indicated, but the fact of the matter is, if you look at the stress that we place on these rods, it really goes up based on the degree of the contour that we're adding to these rods. And it goes up significantly at 20 degrees, it goes up dramatically at 40 degrees, and at 60 degrees, it's beyond the physiologic stress that the rod can maintain. It requires additional support. And I think Sig and I were in Soho when we did this study, where regardless of your expertise and your level of training, no one could bend the rod in the correct predicted anticipated rate. how do we achieve this contour interoperatively? Well, this is basically what happens interoperatively if you don't have pre-contoured rods. And notching occurs with rod bending, and notching also occurs with set screw bending. What are the factors that increase this on biomechanical testing? Well, 3-column osteotomies, pelvic fixation. Well, what do we do in spinal deformity? We do 3-column osteotomies, and we do pelvic fixation. And thanks to Dave Polly and his team, we're not doing any less of that, for sure. So what does the literature tell us about custom implants? Well, basically, if you don't think AI is relative to our planning, it predicts the compensation of the thoracic spine, then half the meeting is irrelevant to you because there were at least 3 symposiums on AI in this meeting. What do we know about this in the literature? The first series out of Colorado, higher rate of meeting alignment, better alignment in the subsequent series that were matched for degree of deformity, and lower rod rate. That's really the lower rod fracture rate. That's really the goal of this. Lower 2.2% down from 9%, and lower rate in 3-column osteotomies as well. Now let's bring it all together. Latest systematic review, essentially the same thing. More likely to meet thoracic alignment goals and more likely to meet your lumbopelvic goals. And then, Sig's going to tell you, I trained at Harvard. I've been doing this for 30 years. I don't have a problem. I've given talks in Honolulu. But the fact of the matter is the way we treat patients now is different than the way we treated patients 30 years ago. And it doesn't stop at patient-specific rods. We have better biomaterials. We have AI to generate digital twins to give us biomechanical profiles. And these can all be applied to our patient-specific planning. And I'll leave you with our series that's been submitted to SRS. 400 patients, 130 patient-specific rods, shorter OR times, less thoracic decompensation, less cervical decompensation at 2 years, fewer cases of PJK, and fewer implant failures. And if you look at this from a cost perspective, Medicare estimated cost of a revision, $95,000, 4 were prevented. There's a lot of cost savings. So thank you for the opportunity.